Good afternoon, good morning, good evening, whatever it may be in your neck of the woods. My name is Ann Brazeau. I'm the CEO and founder of MPN Advocacy and Education International. And today we are doing two things. Today is Rare Disease Day. It's an internationally recognized day, and which we love. And many organizations are doing different things. Today we thought, because the main focus on Rare Disease Day this year is health equity, and of course our organization is working hard on getting rid of inequities, or trying to limit inequities in healthcare for MPN patients. And so I have brought with us today Dr. James Rossetti in Pennsylvania, who many of you have seen before. He is a frequent speaker at our webinars and events. And Dr. Rossetti is just going to share with you some information and some thoughts. And then we'll hear from Julia Ulf, who is actually a patient, but also a health equity and literacy professional. And she will share some things. I will share, introduce you to PDABs, which we'll get into a little bit, and share what's happening across the state or across the country. And then we'll hear briefly from our industry partners. So please help me welcoming Dr. James Rossetti. Dr. Rossetti.
And thank you. It is a great joy to be with everybody today and to kick this off. Your remarks are spot on. We, especially as it relates to all of these life-threatening disorders, and what we realize when it comes to health equity is that many things jeopardize health that we oftentimes don't think about. And there are some experts on this panel today, and of course you're one of them, and everything you're doing is helping to bridge the gaps that exist as it relates to equity and, quite frankly, inequity. And Julia is an expert. I am no expert. I'm a clinician, and I deal with patients with rare diseases every day and see how this group of disorders affects health, but more than that, how communities are affected at large when we talk about inequity in health and what we can do to change that. So I'm humbled to be a part of the panel, and if I could, I'm going to go ahead and share my screen and go ahead and get me into presentation mode. There we go. Can you all see that okay?
Yes.
Very good. So what is health equity? And naturally, as we talk about equity in health, we talk about multiple variables, if you will, as we try to level the playing field for all of humanity to reach their highest level of health. And some of those here from the Centers of Disease Control are listed. And I think as a country, in fact, as a nation, as a world, we have to recognize that there are some injustices that must be addressed and spearheaded. We need to face them head on with a spirit of hope, but also with a spirit of apology so that we can regain trust. And really everything that we do in this medical community of ours is to gain the trust of people we care about, the people that we are, in fact, in service to. And to do that, we have to admit that things have not always been fair. And I'm so thrilled that equity in health is the focus of this year. And I hope that it propels us to continue to address this major problem. There are social, economical obstacles to health and healthcare, and then you throw on top of that certain rare disorders, and it only adds to the mix. But I love that we're starting out with a bigger problem and addressing it fairly, so we can recognize disease, so that we can prevent disease, so we can find disease earlier, and quite frankly, close those death gaps that exist because we're not identifying patients for these various potential areas of injustice, if you will. To do that, I think we need to look at what health is. If we look in the Oxford languages and throughout the various dictionaries, what we ultimately find is a very, I would say, inadequate definition of what health is the state of being free from illness or injury. And we know that is not an adequate definition, if you will. And it actually lists here that the opposite would be illness. We need to expand our definition of what health is and recognize that health is much bigger than the absence of illness. Health is about growth. Health is about community. Health is about service. Health is about access. Health is about awareness, becoming who we are maximally in all spheres of our existence. So this was a nice article I liked that defined, the World Health Organization looked at the idea of what health is just several decades ago and defined health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity, but then further address the fact that of these inequities, if you will, as it relates to health, as a resource for everyday life down there at the bottom. Not simply the objective of living. Health is a positive concept emphasizing social and personal resources as well as the physical capabilities. As I think about that, it is just that. I love the fact that, Anne, you've built a wonderful community to raise awareness. And as a result, so many of our patients come together on days like this to help one another, to recognize and tell us what we have done wrong as a healthcare community. And by the way, as I think about team, I have physician assistant Emily behind me, and Miranda, one of our nurses. One is out, thank God, on maternity leave, doing very well. Maybe you guys could just wave behind me if you would. And I love to this entire day is about community, is about building communities and providing the well-being that is necessary to overcome the injustices that have existed previously. If we look at the U.S. Department of Health and Human Services, then we can start to look at those determinants of health, those social determinants. And I have to tell you, this is an area that is not just a buzzword. Please, for everyone listening, recognize that this is not just a movement in government for the sake of votes, God forbid, but rather it is raising awareness even in people like myself who were completely ignorant of just how much education matters for one individual's health and the health of their family, and not only in the health of their family, but in the health of their community. And what we recognize is that people are diagnosed not only later, but sometimes not at all, leading to great disparities in overall outcomes. And again, I suspect Julie is going to talk a bit about this as an expert in the field. The economic stability, Anne's going to talk about the overwhelming prices of some of the medications. And I know that some of our industry partners are part of this presentation today as well. We need to work together to figure out how to get these costs down so everyone can access the healthcare that they need to maximize all of these areas. And we as a medical community need to look at all of these avenues and see how we, as these large healthcare centers with all of the resources we have, help those communities that are less served, quite honestly, and unfortunately forgotten. And God forbid we continue to forget people who we don't even know their name. We don't even know what their problems are. This is a tragedy that we need to overcome, and we do so today with great hope. Ann and I had a conversation this morning, and everything that we see, we must approach with a spirit of service and a spirit of hope. Where there is service, there is hope, brothers and sisters. I want us all to remember that. It is a great blessing to be a part of this organization, the MPN Advocacy and Education International, but some of the local support groups, to see how that can help us close the gaps as well, to be able to listen to you as patients. I wish I could stay on, and I certainly will listen to the recording. What I want to hear in your patient stories, where we're failing, if you will, where we aren't hearing you, where you don't have access. And these are the things that the dialogue that needs to continue to exist so that we can improve. And I want to close by a few things. And I promised Ann I would talk a little bit about what we can do and what I do in my practice, what Emily does, what Miranda does. Well, one thing is to continue that spirit of service in the setting of community, recognizing that we are a team. we're not only a team that stands above you, rather we're a team that walks with you. And I hope that everyone that's under our care and the care of all the multitude of MPN experts I've worked with, I think share that same idea, is that we want to walk alongside each of you as patients where you are, and help you to get the care that you need. Awareness is one of the words that comes to mind. What Ann's doing, what our local organizations are doing, our local support groups, to raise awareness about these illnesses. Access, accessibility to the providers. One of the things that we do here in our network is, especially with rare diseases, is try to funnel the patients in from the community to get the input of someone like myself who has the luxury of focusing on a disease, the state, if you will, of myeloproliferative neoplasm and the other myeloid malignancies, whereas my community partners see so much more. And I always say I could probably never, I couldn't do it because of what they're required to know. But what we're all required to know is that these diagnoses and the prognostic models that we follow are becoming more and more in depth, so that at least one opportunity to meet with a specialist, I think, can be very, very helpful. What that also means is people like that we work with, the social workers, they might have access and tools, the Leukemia Lymphoma Societies, these advocacy groups, grants, different outlets, people that have expertise in finding resources for you so that you have an opportunity to receive the same care as anyone else with the same illness. But maybe your disease needs to be more tailored. And that really is the beauty of what we do. You're all individuals. And as individuals, your symptoms are different. Your risk of progression is different. We want to make sure that we're giving you tailored medicine through accurate diagnosis, accurate prognosis, making the diagnosis, prognosticating the best that we can, and providing you the resources that you need to be treated. I'm fortunate. My wife runs a free health clinic. And because she's a manager at a health clinic that is run in one of our underserved communities here in the city of Pittsburgh, known as the Neighborhood Resilience Project. It's just one of the many areas that they are excelling in to close these gaps in healthcare inequity in other areas of inequity. But what that has allowed me to recognize is that these clinics need access to specialists as well. I can tell you that I've seen now at least 3 patients who have polycythemia or erythrocytosis and needed further workup because of the fact that my wife was there and had awareness of what I do. It's my responsibility then to go out in these communities and recognize these other free health clinics that frankly I didn't even realize exist, to say, hey, we are here to help you, even if it's a free phone consultation initially. That has been a huge blessing and something I think we can call all of us in these larger health centers to do. And by the way, our own health center helped to fund that department very early on, and I'm grateful for that. So these larger systems are recognizing the inequity as well. Education and what Ann is doing is terrific. Education about these disease states, but before that, education as a whole. Healthcare literacy is so dependent on a variety of things, including earliest education. And these are bridges that must be crossed. Time. When a drug is denied, we need to take the time to do the appeals. And I have Emily who helps me with a lot of those because time is limited, is a limited resource that we have. But the reality is we need to fight for our patients to get the drugs, even if they don't have the resources to do so, as I said. And I want to suggest to you that one area we could do better is listen to our patients. We listen. This whole day is about listening. It's about community and the community so we can close gaps. And what you see here are large disparities in this particular study of 2017, looking at what is important to MPN patients versus what is important to their physicians. And if the two don't align, we cannot give proper care. Yes, we might have knowledge as to what's going to help you live longer. You have the ultimate knowledge as to what we can do to help you live better. And that's really a huge part, as some of you know. How many of you, and I want to hear your stories, had symptoms for a number of years that were maybe ignored with subtly abnormal blood counts? Again, that idea of awareness. We need to listen and not ignore symptoms. And I would close by saying this as it relates to healthcare inequity. These inequities exist in part because of a corporate approach to healthcare. And I think this day is a beautiful reminder to every one of us that what we do is service. And service can only be successful if it's driven by a spirit of love. It cannot be driven by a bottom line. Yes, there are practical aspects, but as a healthcare community, anyone who's called to this ministry is called to do so because they care. And we need to remember that even amidst the growing corporate pressures that we feel in healthcare, it's a real problem. And I'm glad to say that we're starting to address it as a culture in healthcare, so that we can go back to the real ministry of what healthcare is really about. That's ultimately what I think today is about, is a reminder of the service that we wish to provide. This was from a couple of years ago. It came out in a circular on Rare Disease Day, and a patient brought this into me, and it just kind of jumped out at her that she had essential thrombocytosis, and she saw the letters ET on the page. She said that's the first thing that she recognized, and started to underline this, and it just meant so much to her that what was something she had really not heard about before, all of a sudden she started to meet other people who were also afflicted. And what today I think suggests to us is, not only as an MPN community, as MPN patients, we have to recognize that across the spectrum of disease, you're not alone. That's what today is about. And again, I'm grateful. I'm not an expert, as you could probably tell, but I do want to say that we are committed, and I'm grateful that I know Ann is committed, and so many others who are running similar operations in a spirit of service. So I'll close there, Ann, and say thank you very much.
Thank you, Dr. Rossetti. I knew I could count on you for some wonderful insights, and this is an ongoing issue. It doesn't, like you said, it's not going to disappear. It is something that we have to face every day. And I hear from hundreds of patients and thousands of patients actually over the course of 12 months. And I will tell you that we've come a long way in the MPN community. It's marvelous, and the MPN specialists have been absolutely fantastic, including yourself. We've had situations where we have had to call an MPN specialist in a certain city and say, listen, this patient does not have money, cannot afford to come to your institution, but they need you. They cannot go to another person in that community because that person doesn't have the expertise. I have had situations where that physician will say, bring them, we'll figure it out, get them to this place, and we will work with that person. So those are rare occasions, but I do know that the grassroots efforts that we do here, grassroots efforts do work, people. They absolutely do work. And we have had instances where we've had to call on patients to go into their own communities, to their legislators, meet with their legislators, pay attention to what their legislators represent, and what their platforms are on healthcare and inequities, and to vote accordingly and to pay attention. But I so appreciate your participation in this.
And I want to thank you to you again, and just share with you two very, very brief anecdotes, if I can, that were very helpful. Sure. Through these grassroots efforts, I can tell you that one of these local free healthcare clinics was able to identify a man who had a stroke and was ultimately diagnosed with an MPN, and unfortunately did not have insurance, but was able to get at least the start of phlebotomy and systemic therapy. We sometimes think it's not possible. Our management was so responsive to helping this person without dollars and without coverage to get the care that he needed. The local pharmacy was kind enough to give the medication necessary as well. And so these grassroots efforts can only help continue to build. And I will tell you also, through your organization, a woman came to us who was really kind of at the end of the line as it relates to available therapy. And it brings up the issue of access to clinical trials, and was able to have access to trial because of a referral through you. And you have personally helped me with family and friends to find the right expert in their neck of the woods. You know, again, it's community and communication, right?
It
And
definitely is. And I was just going to say, it takes a village. I know that's overused. It's an overused term now. And but I still say it does take a village, and meaning in our MPN community, the physicians, the industry partners, the patients, the caregivers, we all have to be communicating. We all have to talk to each other and you know, remedy some of these issues. But health equity it should be a top priority in on everyone's mind. We live in a society where, you know, people are sick. We are taking so many drugs, and you know, we just need to pay attention to who's accessing those drugs and who isn't, and who needs them and who isn't getting them.
Absolutely.
And but I can't thank you enough. You're a gem in our book.
I'm
And
grateful for yours. It really does. It takes a
yeah,
guy, doesn't it?
we're #1 fans of yours, and we'll see you, I hope, very soon. And stay on if you'd like. Julia will be next, and she will be. Are you there, Julia?
I want to learn from Julia.
Yeah, she's a pro. She's such a sweetheart. She's on our patient advisory council. And honestly, whenever I reach out to Julia, there maybe have been one or two times she has said, no, I'm not available. But please welcome Julia Ulf, who is a health equity expert and health literacy expert. Julia.
Hi, I have to say, Dr. Rossetti, that I loved your presentation, and yeah, I'm just really happy to try to follow you, and maybe speak a little bit from a patient point of view. So I don't know if I'm an expert, but I have been working in healthcare my adult professional life as a health educator. I was a hospital administrator years ago at Sloan Kettering. I focus a lot on health equity and do research and write about it for clients. And I'm also a geek over health literacy, and I'll talk about that in a moment. Let me see if I can bring up my slides. And oh, and lastly, I am someone with myelofibrosis. And let's see if I can pull up my presentation. I may not be good at this. Sorry about that. Oh, there we go. I am sorry.
That's okay, Julia. I think Mallory just emailed you how to do
You
that.
did. And I thought it was
You see there you go.
easy to do, but what's
What is this?
Nope. My apologies. Are you seeing my screen?
I can see you. I can't see your
Julia, when you press on share screen,
Mm-hmm.
do you see a series of boxes?
Oh, I do. Let's see.
there you go.
All right.
There it is.
Okay. Sorry about that, folks. Let's see if we can get this into presentation mode. All right, I'm going to leave it. Sorry. In the interest of time. So to follow what Dr. Rossetti started to share, which is what is health equity, I pulled up the very same definition from the Centers for Disease Control. So in a nutshell, and I'm going to repeat a little bit of what Dr. Rossetti said, you know, health equity is about every one of us having a fair and just opportunity to achieve our highest level of health. And I so appreciate that Dr. Rossetti talked about what is health and well-being. So I'm not going to spend much time on this slide, but to say that the Centers for Disease Control's focus, as is this definition, is largely about all the systems the healthcare system and other systems that affect whether or not all individuals have access to the same elements that contribute to health. I'm going to hopefully drill down a little bit into what does health equity mean at an individual level. So, why does it matter? Health disparities or differences essentially that negatively or adversely affect people who've been marginalized or excluded. And that can be, unfortunately, based on, discrimination and bias towards a number of kinds of groups, from age to economics to racial and ethnic ethnicity or gender. And all of those disparities make it harder for those people, especially within those groups, to achieve their personal, their health and well-being. And when we talk about health, and in healthcare, clinicians refer to health outcomes, which is basically, how well, did a treatment do? How good is our health? What are the end results or the goals? And what has fascinated me, and thank you, Dr. Rossetti, for also talking about this concept of social determinants of health, which is, as a health educator, like that is the bread and butter of what my understanding of health and public health is there are the direct healthcare services you receive, and then there are a whole host of these social factors that also affect your health. And what may be amazing to learn, it was to me, is that your individual health behaviors are only one part or even a smaller percentage of your overall well-being. So if you look down at the bottom, I just pulled up the stat that 30 to 55% of an individual's health, this is based on research from the World Health Organization, that your health is not only based on what you do as an individual, your health behaviors, how you eat, et cetera, but it's also based on all these other factors, whether or not you can get to health services, whether you get quality health services, as was alluded to in talking about rare diseases, the costs of care, and whether it's affordable, where you live. Do you live in an area that's near a factory that pollutes and has the potential to cause systemic illness? And then do you experience discrimination or bias? And we'll probably talk about that a little bit more. So there's a whole range of factors that affect how an individual is perceived in a healthcare setting and the kind of services that they get. I want us to talk just briefly. There's a lot going on here. This is a slide from the American Association for Cancer Research. This is from their 2021 report on disparities, again, differences in cancer health and outcomes based on race and ethnicity. And just a few, as I said, there's a lot in there, but I wanted to point out a few examples. If you look at the yellow bar on the left, in comparison to white American population, the Black population in the US has more than double the mortality rate for multiple myeloma, double. And we're talking about mortality. So that means that a significant percentage of Black folks who are affected by multiple myeloma die as a result of multiple myeloma compared to the white population in the US. That's a disparity. There's a difference that is causing a significant, significantly different result in healthcare for a population. In the right column, I wanted to point out the little pie chart there on clinical trials. It certainly is very relevant to those of us with MPNs. So between 2009 and 2019, the FDA that approves, the federal entity that approves medications in the US, approved 81 oral anti-cancer chemo drugs. That's great news. Based on 142 clinical trials, but only 52% of those trials reported on race and ethnicity. And that is thankfully changing. And there are many systemic efforts to capture that information and to encourage and increase the diversity of clinical trial participants. So in that pie chart, what you see is we are still in a place where over 70% of clinical trial participants are white, and I believe many more males. And yet only 2.5% of participants are Black. And in contrast, about 15% of the US population that has cancer is Black. So there's a disparity right there. And it's significant because people from different ethnic regions, from different regions, have a host of differences in terms of the pathophysiology of a disease, in terms of environmental factors, economic factors that affect how they respond to a treatment in clinical trials and the safety of that treatment. So it's essential that we have true diversity, gender, socioeconomics, ethnicity, et cetera, within clinical trials so that the results are more representative of and useful when applied to particular populations. So that's just an example of, those are just examples of the kinds of disparities that exist. It's not specific to MPNs, but cancer in general. So I wanted to talk about at an individual level, what each of us on this call can do. So this is my steps you can take for better MPN health outcomes and maybe to reduce health disparities. As I was getting ready for this presentation, I thought, oh my gosh, I missed so much more. So I'm going to try to layer that in. But I'll just go through these quickly. One is, as already mentioned, is attending webinars like this. So those of you who are listening are working on your MPN health literacy. So you are improving your knowledge and understanding, and that will enable you to take better control of your health. And when it comes to MPNs and as a rare disease, the more you know about treatment and how you should be monitored, the more you can intervene on your own behalf. And as Dr. Rossetti mentioned, and I'm an advocate, is that your ability to see an MPN specialist, if you can, is really essential. And I know that that MPN specialists are not available everywhere. However, thankfully, through virtual second opinions, for example, there are more avenues to be able to see an MPN specialist. And I believe that and I see an MPN specialist and I will travel. I know I'm able to take the time and spend the money to do that, and not everybody can. But the ability to see someone who has the depth of knowledge and expertise, as Dr. Rossetti referenced, makes a difference in terms of their recommendations on treatment, their ability to manage and monitor you, to consider other patients that they have who they're caring for, who have a similar experience. I know my MPN specialist is able to say, yeah, I have a few other patients who have shared what you've shared, and here's what I recommend. And a physician in the community who doesn't see, based on the numbers of people with MPNs as a rare disease, may not be able to speak to their own individual expertise. They may be relying on guidelines. My other recommendation as a health educator and an MPN patient is knowing what your risk status is for your particular MPN. And then that will help you know also what are the goals of treatment. So we need to know what we're treating. When I was diagnosed with ET that then transformed into myelofibrosis, I was seeing a lovely community hematologist oncologist, but he wanted to put me on a drug that was specific to one of the high molecular risk mutations that I had, but he really didn't have a goal for it. He just sort of knew that it was effective with other illnesses. So that was when I questioned, what are we doing, and why would you put me on that drug? And that led me down to another path of ultimately finding an MPN specialist. So my rallying cry is, you have a right to ask. It's your body, it's your health, it's your well-being, and you also have a right to understand what the recommendations are. From a thinking about as an individual and thinking about your medical appointments in advance, it's kind of a drag that being a patient is kind of a job, but if you can think of it as helping you in the long run, planning for your visits, at least spending a few minutes thinking about kind of getting your thoughts together, taking notes in some form, whether that's printed or on a smartphone or whatever you do, both before the visit and at least at the visit. And here are some of the things that I think are really important, is thinking about how you're feeling. As a health educator, I've been working on developing patient ed materials for years. And those of us who think we can remember what happened 3 months ago are mistaken. And I think tracking symptoms and tracking how they change in level of severity is really essential to share with your provider. And as Dr. Rossetti said, this is a relationship, and your provider should be listening to you and should care about how you're feeling, not only from a clinical point of view, but also from a quality of life point of view. So not only what you're feeling and experiencing, but how it's affecting your functioning, your ability to live the life that you lead. And a provider doesn't know what your baseline energy level is or what you do in a day necessarily. And that's where you need to communicate how illness and treatment are maybe affecting you. As well, obviously, treatment side effects or what you may perceive as a side effect is important to share with your provider, and it will help them figure out and sort of troubleshoot together what can be done. I think every treatment that I've been on for myelofibrosis prior to the proliferation now or availability of more JAK inhibitors has meant being on a treatment that caused a side effect. So for me, every treatment meant a side effect that had to then be treated. And I really worked kind of trial and error with my MPN specialist, who in some cases, getting that additional treatment helped me stay on the treatment. And that's really important if you're on a medication that you hope will really help you. Being able to stay on it is going to be important if it's appropriate. I think it's really important to write down during visits or capture in some way, and that could be also with a family member or friend who's with you at the appointment, to remember is what your doctor or your treatment team recommends, and how to characterize like where you're at, what your prognosis is, what your outlook is, or what they're thinking about. I know it falls right out of my head. So capturing in my MPN specialist words what they said so that I can go back to that and remember, okay, all right, so this is what we talked about. We talked a little bit about clinical trials, asking about them, being aware of them, asking if there are possibilities of participating in a clinical trial in your community. There is a fair amount of research, unfortunately, in terms of discrimination and bias, that providers may unconsciously assume that people of certain ethnic groups can't participate in a clinical trial or won't participate in a clinical trial or won't be adherent to a clinical trial. And as an individual, you can counter that by demonstrating your interest and also asking about, Anne brought this up, and I should have said more about this, is reaching out to or asking for support from the MPN and blood cancer organizations that can help, say, reduce the cost of travel to a clinical trial site, for example. And lastly, I just wanted to talk a little bit about if you perceive that you have been treated poorly or been discriminated against or been feel unsettled in terms of maybe feeling like you were not respected and listened to during a provider visit. I think that's important to be aware of and consider sharing and providing that feedback. And these days, we all see a provider and then we get a survey after that. And that's one place to provide that feedback. I have also reached out to the patient experience department, and I did that recently for one of my adult children who had a very negative experience getting an emergency CAT scan prior to what turned out to be the need for emergency surgery. And they have mental illness, and that tech complained about having all the crazy patients that day
Mm.
in their presence.
Mm.
Yeah, yeah. And so it is, you know, speak up, and you have a right to be treated with respect, and follow the process if you feel you haven't. I think it's really important for the providers, for the institution to know, and Dr. Rossetti commented on it, we need feedback. And so those are my like essential points. I have more that I could say, but I'm going to be quiet now and
Well, I can't thank you enough, and you hit on some really very major topics here. And I'm sorry, but the sun is blaring on me right now. I first of all, we hosted a focus group a couple months ago with a very diverse group of patients, and the things that we heard were terribly upsetting.
Yeah.
And you know, it happens in every disease group. I was in breast cancer and prostate cancer prior to these 21 years, but I can tell you that the issues are still out there. They're all still the same, that if there are economic issues to healthcare, they end up in the emergency department, and very often an MPN is overlooked or not even diagnosed in an ED. And other disparities that you mentioned, you know, the ethnic and racial disparities, we strive to change that, and we will work till the day I die on these issues.
Well, and it's multi-level, right? So
Yes,
healthcare providers, healthcare institutions, and I know there are many efforts. I've worked on some of the programs and written about, for example, you know, unconscious bias from healthcare providers. They are humans, and we all have biases, and we need to be aware of them, check them, and work at eliminating them. Yeah,
right. And I taught a couple of adult, actually for corporations, on discrimination and harassment and those kinds of things, and it's all intertwined. And of course, we have the Women in MPN program, which was rooted born. Yeah, thank you. But it was born out of a necessity to speak to women who were seeking, you know, help from physicians with their MPNs, and being told that, oh, this is your age, this is what you're going through, this is not your MPN.
Right. Women's point of view are discounted. Their symptoms are often discounted. Yes.
Yeah. And so, and then of course, our African-American patients who are telling me that they're not given certain medications, or they just assume that they're not going to be able to afford certain things, so they get the very minimum, and other issues that we're aware of. But you know, we will continue to strive to improve health equity and to improve access to our physicians and to our treatment options that are available today, which did not exist when I first started in this space. And so we are always here for you. And our number one concern is the patient, always. And as you being one of those folks, you know, we've known each other now almost 20 years, and you've been through a lot, and I just can't tell you how much I appreciate you and your time.
Well, thank you. Glad to be a part. I love the Women in MPN conference. It's really my favorite, and I get so much out of it. And I know you and I have already talked about, I'm going to be traveling during this year's conference, sadly, so I'll miss it.
Yeah, and we'll miss you. So we're going to move on, but thank you, Julia, and Dr. Rossetti, if you're still with us, thank you for staying and for your presentation. And I am going to introduce to you, if we can move that. First of all, that we're very happy that Rare Disease Day is focusing on health equity. And that is precisely why I brought Julia and Dr. Rossetti on board, because of conversations in the past with Dr. Rossetti and knowing how much he cares about the subject, and for Julia. But we are going to talk briefly about PDABs. And we were kind of nudged by one of our partners, and then delved in full force into some research. And Natalie did a ton of research, and I have since then, since our conversation. And PDABs are Prescription Drug Affordability Boards, and they are being formed to protect the safety and health and economic well-being of states' residents by taking steps to increase access and affordability to prescription drugs, which is what we need to do and what all of us need to pay attention to. Several states have already considered enacting legislation and have created boards. The PDABs assess the affordability of drugs and recommend ways to reduce spending. The board may set up upper payment limits, which could limit the amount payers, providers, and pharmacies and patients can pay for prescription drugs. And much of this sounds very good. 4 states enacted PDABs so far. Colorado is probably the most assertive. Maryland, Washington, and Minnesota. I know that Michigan is, there are some bills in the House right now, and our governor is having conversations, and I'm going to be meeting with her actually in a couple of weeks, and to share our perspective from a rare disease perspective on what might happen, what could be the positives for our MPN patients, and what might turn out to be negative for our MPN patients. The biggest thing for us is that the patient voice has to be at these tables. They do have open meetings in Colorado anyway, where anyone can attend online. And but we actually need a voice, and whether it's an advocacy group like ours, but I really believe that the patients need to be paying attention to this, and to we will figure out some grassroots ways in which you can have a voice, or at least talk to your legislators and try to be more involved with this. So 16 other states are considering PDAB bills. If enacted, these bills would give a state PDAB the authority to set upper payment limits on drugs that it finds affordable. In other words, the board may recommend UPLs for specific drugs deemed excessively expensive. As we know, rare disease drugs happen to be very expensive. And so there's going to be a lot of conversation around this. I don't want to give you all this information and you saying, my God, what is she talking about? We're still learning, but just know that we are paying attention to this. We are paying attention to how this is going to affect you as a patient with a rare disease. So what this means to the patient and payer is that patient access, while aiming to lower costs, patient access to specific drugs might be negatively affected. Patient cost sharing, patient access to specific drugs might be negatively affected if they fall apart or fall under the payment limits. The payer impact, these limits could reduce overall spending on prescription drugs for the state and participating insurers. And rare diseases, 2 state PDABs in Washington and Oregon have excluded drugs that only treat rare diseases from affordability reviews. 1 state, Colorado, is considering legislation to add an exemption for rare disease drugs. The debate is going to be this approach to drug affordability, and it's going to be ongoing. It's always something on all of our minds, but we really need to be paying attention to this. So for MPN Advocacy International, our priority is always and will always be to preserve access to care and treatment for MPN patients. We do this by sharing evidence about the benefits of MPN therapies and encourage these reviews to center themselves around the needs of our patients, always. We understand there is a need to increase clarity of what prices are being charged by different parties. We need to improve affordability and address sustainability of the healthcare system. Solutions to address affordability cannot come at the expense of patient care, ever, in our mind. The patient must be at the center of the discussion and include patient voices throughout the process, and consider how the board's decisions will impact a person's ability to access their medication. You know, as I mentioned earlier, we constantly are trying to help patients who cannot afford their treatment but need it. And think about from the physician standpoint, when they know the patient can't afford a treatment that is much better, that is doing very well in a lot of different patients, and they may be hesitant to prescribe that drug for that reason. Finally, we believe it is the responsibility of both states and manufacturers to ensure that access, that our people with MPNs who benefit from current therapies continue to have access to them and continue to be able to afford them. So just know this was a brief overview of what PDABs are, what they intend to do, and that there will be a lot more discussion about this. If you live in a state that has a PDAB or is forming a PDAB as we do in Michigan, we will be having lots of conversations locally because they can make their own rules in each state because they are state run. And so we need to pay very close attention. You'll be getting briefs from us as we go on from here. So that's it for us, except that we want you to hear from some of our industry partners. And I wanted to point out that the approved drugs for MPNs currently are here and where you need to go if you need assistance in getting your drugs. The one thing I love about our partners' willingness to hear the patient voice, number one. And number two, when my big thing, they all know it, is you can make your drug all day long, but if our patients cannot access that drug, then, you know, that's not okay. And so Insight, who makes Jakafi, has insightcares.com. Pharmacentia has Best Remy, and there's a resource, pharmacentiasource.com. GSK Ojara has gskforyou.com. And Sobi, who makes Vonjo, has CTI Access, and there's the phone number. We also partner with the PAN Foundation, and they are wonderful. They will hear your story, hear what your needs are, and offer you, they'll be able to help you and decide how much they can help you with in terms of financial assistance. So we will go from here to our industry partner updates. And I believe Kristen Griffiths, who's the Associate Director of Communications and Patient Advocacy, is with us today. Hi, Kristen, and she's going to give a brief update.
Hello. As Ann said, I'm Kristen, and it's really an honor to be here with all of you on Rare Disease Day and represent Insight. And I'd like to thank you, Ann, and your team at MPN Advocacy and Education International for giving me a few minutes to speak about Insight and our commitment to patients. And a little bit of background on Insight. So Insight's a Wilmington, Delaware-based biopharmaceutical company. We're committed to making a difference in the patient lives through scientific discovery. Rigorous science is at the core of everything we do, from discovering, developing, and delivering novel medicines that meet the serious medical needs in oncology, as well as other disease states. As Ann mentioned, one of our most important commitments is to help ensure that appropriate patients have access to the medications that they need. And as Ann talked about, for this reason, we've developed a patient support program called Insight Cares to help appropriate patients and healthcare providers access their prescribed medicine. So for eligible patients, Insight Cares offers prescription drug insurance verification and prior authorization support, free drug and copay assistance for those who qualify under the program's terms and conditions, as well as ongoing education and support from a representative. So patients, if you have concerns about access to prescribed medications, please contact Insight Cares for assistance. That information, as Ian shared, can be found at insightcares.com. And we highly suggest any eligible patients enroll in Insight Cares, even if you don't think that you'll need assistance initially, just because if you're enrolled, we'll be able to help you get access more quickly if needed. Just a note on clinical trials. We are currently enrolling patients in clinical trials for MPN. So if you're interested, please contact your healthcare provider. Details about our clinical trials can be found at insightclinicaltrials.com. That's INCYTE clinicaltrials.com. And then finally, we really strive to support the patient community and integrate an authentic patient voice throughout our initiatives. And that's why partners like this that we have with MPN Advocacy and Education International have been really key in helping us understand the unmet patient need as well as the unmet caregiver needs, including raising disease awareness and providing educational support to the community. We host a website called voicesofmpn.com where we provide access to NPN information. And also, I'm really excited to announce that today we have launched a program called the Unseen Journey. The goal of this program is to raise awareness of common MPN symptoms and encourage those living with an MPN to proactively identify, track, and discuss their symptoms or any changes in their health with their healthcare team. What's special about this program is that it highlights the stories of people living with MPNs and helps make the unseen physical toll of their symptoms seen through generative AI intelligence and imagery. And it was created from the words and experiences of real patients. So if you're interested in checking out these stories, they're really striking and beautiful, please go to theunseenjourney.com. And the last point I'll make is that we also have a program called MPN Heroes, where we publicly recognize individuals who have excelled in caring for patients who have an MPN or who have advanced the science in MPNs. And the nomination window for those individuals is open today. So you can go to mpnheroes.com and put in your nomination. And finally, we at Insight, we really strive, we really believe that industry and patient groups can find a common ground to develop collaborative partnerships resulting in meaningful activities. And that's why programs like this allow Insight to use our resources to help improve the lives of individuals most impacted in the diseases in which we work. So thank you so much. Back to you, Anne.
Thank you very much. And I'm happy to hear all of those updates. That's great. And I know firsthand that Insight Cares has helped a lot of people with MPN. So thank you very much. And we will move on to GSK and Whit Hargrave, who's the patient engagement liaison. Hi, Whit. Can't hear you.
How about now?
Yes.
Good afternoon, everyone. Thank you for allowing me the opportunity to speak with you today. My name is Whit Hargrave, and I'm a patient engagement liaison with GSK Oncology. GSK is a global biopharma company with a purpose to unite science, technology, and talent to get ahead of disease together. GSK is focused on maximizing patient survival through transformational medications. Our focus includes immuno-oncology, tumor cell targeting therapies, and synthetic lethality. Our goal is to achieve a sustainable flow of new treatments based on a diversified portfolio of investigational medications, utilizing modalities such as small molecules, antibodies, and antibody drug conjugates, either alone or in combination. On September 15th, 2023, GSK announced that the FDA had approved Ojjaara for the treatment of intermediate or high-risk myelofibrosis, including primary myelofibrosis and secondary myelofibrosis in adult patients with anemia. Ojjaara is a once-a-day oral JAK1, JAK2, and activin A receptor type 1 inhibitor, and is approved for both newly diagnosed and previously treated myelofibrosis patients with anemia. Ojjaara has been studied with regard to key manifestations of the disease, namely anemia, constitutional symptoms, and splenomegaly. Please be sure to consult with your physician regarding your care and treatment options. To close, I'd just like to add that we are so grateful to the MPN Advocacy and Education International community and the entire myelofibrosis advocacy community for the work that you are doing to raise awareness and educate patients and their care partners about this disease. We appreciate the partnership we have with you, Anne Brazeau, and I thank you for this opportunity for me to tell you and your patient and care partner community about what we are doing at GSK Oncology. Thank you.
Thank you, Whit. Thank you. That was very nicely done. Thank you. And now we'll move on to Sobi and Leslie Ferber, who's the Associate Director of Patient Advocacy. Are you there, Leslie? There you are. Hi.
Hi. I was trying to be really good and having my screen off, but that also.
Okay, well, welcome.
Yeah. Thank you. Well, good morning, good afternoon, depending on where you are. Thank you, Anne, for hosting this. This definitely warms my heart because it is definitely a topic that is very important. I'm the Associate Director of Patient Advocacy at Sobies, leading the hematology side of things, which includes MPNs. Some of you may recall my colleague Dave Dubinsky, and so or even remember the name CTI Biopharma. So we are now one as Sobi, and then we are the maker of pacritinib or Vonjo, as some of you hear it. Our mission is really to make innovation care possible for people living with rare and severe diseases. And just like, Dr. Rossetti said, you're not alone. And really, this means that there are organizations like this that provide support and for you all, but also kind of allow you all to, do advocacy on your behalf. I love how health equity now is no longer just a buzzword, but something we could all work towards. Something Sobi put efforts into is providing meaningful educations to the MF patient community. And, to be frank, there has been a lot of advancement in the understanding of the biology of MPNs and those advancements in general. And we could have all the advancements in the world and all of the knowledge, but it really doesn't matter if you can't have access to it, right? So I'm really glad that the topic of health equity were being discussed because just like Anne said, like no one can do it alone, and it really does take a village. Because we recognize that it takes a patient, clinicians, and industry to work together to improve therapies and patients' life, especially in an area of unmet medical needs like myelofibrosis. So we're really glad that we could be part of that team. Over the past several years, there has been a lot of advancement in understanding of biology of MPNs, and this includes development and studying of Vonjo. Vonjo is a unique JAK inhibitor developed for MF patients living with low platelets and low blood cells. Vonjo has a unique mechanism of actions which differentiate it from other JAK inhibitors. Vonjo is a JAK1 sparing, targeting JAK2 and IRAK1. All of these are important targets for MF patients living with low platelet levels. We have learned that maintaining JAK1 signaling is essential for platelet production, stem cell activations, and innate immunity. Of course, these are, I said a lot of scientific words, but that also means that it is a great conversations for you to have with your providers. As I close, I'd like to commend everyone who's taking the time to be on calls like this, because it is so important to stay knowledgeable, not only on the science, but really the holistic view of health as we continue to learn more in the MPN space. So thank you, Anne, for allowing us to have the opportunity to speak in this platform, and then I will kick it back to you.
Thank you very much. I truly appreciate our partnership, and I appreciate what you have shared. In closing, I would just like all of you who were with us today, this has been recorded, so it will be available, we hope, later this afternoon. And just know that we are here. We're working hard to understand some of the nuances of health equity and what we need to do as an organization to make sure that all of our patients and are receiving the care and access that they deserve. And so please let us know if you need us for anything. And we will be in Grand Rapids, Michigan, April 25th with a live program. If you are able, please join us, and we will be in touch soon. Thank you.